Okay, everybody, welcome back to another ultrasound lecture. And this is Dr. Fox once again going through some new material here, some respiratory ultrasound. But before we get there, I just want to tell you about a little bit of my travels. I was last week in Manila in the Philippines teaching at the University of Santo Tomas, where they have a wonderful university. They have a 4-year program with 500 students in each class per year. And these are the faculty that you're seeing here. And I went there. It's about a 16-hour flight if you connect through Tokyo. And I went there, and obviously I fell asleep here at the end of the whole thing. But everybody was very excited to learn ultrasound, integrated into their curriculum. So it was a really wonderful opportunity, and really, really cool people down there, super motivated to do it. So that was a lot of fun. And then when you get this lecture this coming week, I'm actually not going to be there. I'm going to be down in Australia at the University of New England, where I was maybe 10 months ago or so. This is a picture of the university I took last time I was there. So it's a beautiful place here in Armidale, Australia, where we're basically doing the same thing, integrating ultrasound into their curriculum as well. And so you fly to Sydney, and then you take another flight up to Armidale. It's a wonderful sort of rural part of Australia. Anyways, just to kind of keep you updated on my travels as you go through these lectures here. This is switching gears now to pulmonary ultrasound, and we're going to be talking about just a couple things here, some little bit of pulmonary anatomy, but also what happens when you get pulmonary edema, a collapsed lung, as in a pneumothorax, and pleural effusions or fluid around the lung, and then finally what pneumonia looks like on ultrasound. So, the problem with patients sometimes, they come in and you're teasing between two different diagnoses. This is a classic situation here that a lot of physicians are faced with, whether you're in the emergency department or outpatient clinic or up in the ICU. 56-year-old guy comes in, big smoker, and he's got also a known poor ejection fraction of his heart. 35% is definitely low. It's abnormal. And he comes in with shortness of breath. And so, it kind of always boils down to the same dilemma. Is this patient suffering from chronic obstructive pulmonary disease from his long smoking history, or is this congestive heart failure from his poor left ventricular function? And that's something that I think ultrasound can help tease out. In fact, there's a lot of good evidence out there now in point-of-care ultrasound looking at chest ultrasound being superior to chest x-rays for differentiating a patient who's in congestive heart failure from one who's in COPD. In fact, to the untrained eye, both these images sort of look like snowstorms, probably to a lot of people, but if you look closely, you could tell that this has like lines going this way, and this has lines going, horizontally. And they're actually quite different. So this is the COPD patient, and this is the CHF patient. And I'm going to teach you that right now, how to help differentiate that. But we can use ultrasound in the chest to diagnose alveolar-interstitial syndromes, pneumothorax, pneumonia, COPD, pleural effusions, hemothorax, and also abscesses and tumors in the lung and chest wall. And then ultrasound also helps guide painful procedures. I like to say anytime I put a sharp object in a patient's soft tissue, I'm going to use ultrasound to help guide it. And these are the kinds of things that we can do using ultrasound. And there's different zones that you place the transducer on the chest. One is the anterior zone, or this is where you can see the intrapleural air like pneumothorax, and this is the anterior area. And then you've got the posterior lateral zones here, which is where you see consolidations and fluid collections better. And then finally, you can see in all zones, you can help differentiate interstitial alveolar fluid quite well in those areas. So the two transducers that we use to do lung ultrasound are the high-frequency linear transducer that goes from 5 to 10 megahertz, and also the lowest frequency phased array transducer down in that 1 to 5 megahertz range. And this is good for getting between the ribs, and this is good for using the ribs as a landmark to see the pleural line, as I'll explain here in a minute. But if you're running into problems seeing an unclear image, some of the tips that you can do, you have to think about are, if the patient has air in their subcutaneous tissue, meaning did air get up right underneath the skin? We all know that air is the enemy of ultrasound. So if air is underneath the skin, you're going to have a lot of problems seeing past that air. Another thing is if a patient has a collapsed lung, you're not going to be able to make a lot of sense out of that lung other than the fact that you can diagnose it, that there is a pneumothorax. But in terms of seeing what pathology is going on in that lung, like pneumonia or pulmonary edema, you can't see if the patient has a collapsed lung. Sometimes it's really important to reposition the patient. That's particularly true when you're doing a pneumothorax evaluation. So if you lay the patient flat, air travels anteriorly, and that's really the best way. We had a false negative ultrasound last week for pneumothorax in a patient who was sitting upright in the trauma bay for some reason. So you really want to have the patient flat for doing pneumothorax. And as we know from other types of ultrasound, it's helpful to move the patient around, and that can be true as well in dealing with some other types of pathology. You want to get overlying obstructions out of the way, like a brassiere or like the EKG leads or tape or things like that. And then you want to make sure you're using enough gel. Gel is the coupling media for ultrasound that is necessary. And so when it comes to lung parenchyma, if you're trying to figure out if it's normal or not, the first question you want to ask yourself is very simply, are there A lines present or are there B lines present? And this is actually quite easy to do. What the heck is an A line? An A line is that horizontal, repetitive, reverberation artifact that originates from the pleural line. Now we can see this in normal lungs, or we can see it in the setting of a pneumothorax actually. It's an artifact. I want to emphasize that, the fact that it's a reverberation artifact that we can see. Now, what we're looking for is the repetitive sign. So that's the chest wall up there, and we can see the rib shadows. This is using a linear probe. In this case, it's the L25, but got the linear probe. And the distance from the chest wall down to this first line right here, that's the pleural line. And that pleural line represents the interface of the visceral pleura, or the pleural that's on top of the lung itself, and the parietal pleura, or the pleura that's on the chest wall. And we call that the VPPI, or visceral parietal pleural interface, VPPI. And we see that sliding back and forth in a patient who lacks a pneumothorax. And I'm going to get into that a little bit more in a minute. But just keep in mind that there's equidistant lines between the skin line and the pleural line, and then the next artifact, which is the A line. So that's the whole nature of this business. See, air is not a good transducer of sound, so sound scatters at the air pleural interface right here. That's the pleural line, and this is using now the phased array small footprint low frequency transducer, where we have this sector shape here, and you can see this linear pleural line sliding back and forth, and that's the actual VPPI right there. Okay, that's the pleural line. And not seen well are rib shadows. Maybe I can kind of hallucinate one right here. But that's the thing, when you get between the ribs, you don't see the rib shadows when you use a small footprint probe, as opposed to that linear probe where we could actually see both rib shadows. Now from that pleural line, some of these waves like reverberate back to the probe and then create an equidistant and parallel bright arc known as an A line. And this is what an A line is right here. Notice it's the same distance. The distance from the skin line to the pleural line equals the distance between the pleural line to the first A line, and so forth. Another A line is seen down here. And so those are horizontal artifacts, A lines. Now, if you have absence of A lines, that means that something in the lung is replacing that air with the substance that can transmit a sound wave. Right? So air is the enemy of ultrasound, but when you replace air with blood or fluid or infection or congealed blood like a contusion or more of a solid structure like a tumor, well, then you're going to lose those A lines, that artifact. Okay, so which begs the question, what are B lines? Well, B lines are well-defined hyperechoic comet tails, vertical lines that extend down from the pleural line. So like here's the rib, here's another rib, this is the pleural line. We have absence of those A lines, but we have them replaced by B lines. Now you can have a couple of B lines and that can be okay, 1 to 4 specifically, but when you've got multiple diffuse B lines, that's abnormal, that's pulmonary edema. And what happens is you've got the interlobular septae of the lung here. These are interlobular septae, And you can see these interlobular septae here, outlined by the yellow. These interlobular septae, when filled with fluid, okay, well now the sound can conduct down through that fluid. The fluid goes in the interlobular septae of pulmonary edema. And that's what happens when you get congestive heart failure. The fluid builds up in these interlobular septae and is now conducted by the sound, and that's what a beeline looks like. So again, over here we can see, once in a while we see a few beelines. These are rib shadow, pleural line, pleural line. We can see once in a while some beelines there. 1 to 4 beelines can be okay, but over here we see diffuse beelines coming down, and that's pulmonary edema. Another example here, pulmonary edema using a sector transducer conducts all the way to the bottom of the screen. Lots of different terms for this I won't bore you with, but I like to just use the term beelines, and you can see the multiple beelines there. Another example here, when fluid replaces air in the interlobular septae, we have conduction of the sound to the bottom of the screen in a common tail artifact known as a beeline. Okay, and here we can see normal A lines. They make equidistant arcs coming down here. These are A lines. The first one is the pleural line, from the skin of the pleural line, and the equidistant arcs that come down horizontally. Over here we have B lines. So in this case, if you had this patient who had a history of COPD and CHF, you'd be thinking COPD exacerbation, give the patient steroids and albuterol. Over here, we're seeing in the same, if it was that same history, CHF versus COPD, we're thinking a medication that can help get the fluid off the lungs, such as a loop diuretic like Lasix. And that's how ultrasound can help you there in the lungs. Diagnosis? B lines, right, pulmonary edema. Good. Now, there is a chest x-ray correlation here if you wanted to look at something called curly B lines. And it's cool because it means sort of the same thing. This is that interlobular fluid that made it out to the lateral chest wall. And that's what you're looking at right there. That's that interlobular fluid. So if you put a transducer right here, the sound conduct right down that fluid. Switching gears now to talk about pneumothorax. Pneumothorax is where the lung collapses away from the chest wall, as in this diagram. Actually, this patient right here has a pneumothorax. But it's very hard to see on a chest x-ray, particularly when the chest x-ray is taken in a supine patient, one laying on their back, in an anterior-posterior projection. So an anterior-posterior chest x-ray only has a sensitivity of sometimes as low as a coin toss to pick up a pneumothorax. And that's because on the CT scan here, you see if you did an x-ray on the same patient, the x-ray would have to go through skin, fat, sometimes breast, muscle, bone, air. This is the pneumothorax right here. This black stuff here is the pneumothorax. This is the lung that's collapsed away. Then it has to go through the heart, then the lung, and then muscle, bone, fat, skin, and then you've got a chest x-ray. It has to go through all those layers. And then that's why you've got all these things like shadowing each other, and that's why it's very difficult to see pathology on x-rays, which is why slices like CT scans have a much better test characteristic to pick up pathology. And ultrasound, like its brethren with CT scan, also is a slice type of technology. And so the more I think in terms of slices, the less I want to think in terms of rasterization or flattening out of multiple layers, to borrow a term from Photoshop, rasterization. Okay, so ultrasound is pretty good. The data is out there. Another article was published in February of 2012 doing a meta-analysis and showed that indeed ultrasound is much better than plain films to diagnose a pneumothorax when using the gold standard of a chest x-ray. How do you do it? You take a high-frequency linear probe. That's my favorite way to do it. You put it in a supine patient, like the second intercostal space. You've got the probe in a vertical orientation or in a sagittal plane. You go to the midclavicular line. If this is the clavicle here, we're sort of in that midclavicular line. And then we're going to watch the patient breathe in and out 4 or 5 times. And then we're going to slide the probe inferior laterally until we get down here to like the 10th, 11th intercostal space in a coronal plane. Over here, we're sagittal, which means longitudinal when placed from the anterior part of the body. And over here, we're coronal, which means longitudinal when placed along the lateral aspect of the body. We're going to look for the pleural line. We're going to make sure it slides. And then we're going to do something called sky, ocean, beach using our M mode. I'll explain that technique in a minute. So once again, pleural line. It's between the ribs. The ribs are landmarks. And we're going to see if that pleural line slides back and forth. And sometimes we'll see little comet tails coming down, or a couple of B lines will be coming down from that pleural line. Now, if you have a pneumothorax, air displaces that interface, making it impossible to see the sliding. Perhaps this will help understand it better. This is a CT scan with an ultrasound probe on it. Okay, so here's the skin, fat, muscle, bone, bone, muscle, lung. Now, normally you don't see lung on ultrasound like you do nicely on a CT scan, but this is for demonstration purposes. You put that linear probe between two ribs. Okay, so here we are, rib 1, rib 2, and between the ribs we have the pleural interface. The lung slides back and forth with that pleural interface. Okay, now, as the patient's breathing in and out, we can see the visceral parietal pleura sliding against one another. We don't actually see the lung itself because air in the lung impairs the transmission of the sound. But we can see the interface of the chest wall and the lung together sliding back and forth. Now, if the patient has a pneumothorax, which means a collapsed lung, where air gets between the lung and the chest wall, that's what a pneumothorax is. Well, now we are unable to see the lung sliding because there's air in the way. Air, the enemy of ultrasound, separates the pleura so that we can no longer see it on ultrasound. So it's the lack of lung sliding that is the pneumothorax. So, another example, linear transducer in a sagittal plane. That's why I see maybe this is like rib number 2 here and rib number 3 over here with their corresponding shadows. I like the sagittal plane because it gives me this nice landmark to see my pleural line. And these are little comet tails that make it to the bottom of the screen, or B lines sliding back and forth. And that lung sliding tells me there's no pneumothorax. Sometimes that's described as ants marching back and forth. But whatever you want to call it, that's lung sliding. That's normal. This is what a pneumothorax looks like. PTX is the abbreviation commonly in the medical literature for pneumothorax. So you see the ribs, you see the rib shadows, and in between the two, this is the pleural line here, we no longer see the lung sliding. It's just kind of static as the patient's breathing in and out. This is a pneumothorax. There's no lung sliding. I see one rib shadow here, I see the pleural line here, and indeed, I see the lung sliding back and forth. Another technique is called sky, ocean, beach. So if your eyes are unable to see that lung sliding, maybe the machine can see it for you. And M mode is the way the machine sees things that are moving. So this is the M mode spike seen right here. Okay, so this part of the spike up here corresponds to the skin right here. This next part of the M mode spike corresponds to muscle. And then this part of the M mode spike corresponds to more muscle. And then this part of the M mode spike here corresponds to this white line right here that is the pleural line. So notice that we have all this horizontal stuff. Horizontal means static. Grainy means motion. That's why it's called M mode or motion mode. You can activate it by hitting the M mode button here or by depressing the button that corresponds to the M mode soft key here. So a pneumothorax looks like, sometimes people call it the seashore sign. Okay, the seashore sign is the normal lung, sky, ocean, beach. This is normal. The transition zone is seen right here between normal lung and pneumothorax, or what they call the stratosphere or barcode sign here. I don't want to confuse you with a bunch of different terms and colloquialisms, but everybody does kind of refer to this as sky, ocean, beach. Where the sky and the ocean are separated doesn't really matter so much, but do you see beach or not? Over here, we see just straight up barcode all the way down. Sky, ocean, 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 sometimes people say. Okay, so rib shadow, pleural line, sky, ocean, beach. No pneumothorax. Over here, on the other hand, rib shadow, pleural line, M mode spike, and you come down about halfway down that spike. That's where you should see the pleural line, somewhere right here, maybe over here. No beach. Barcode sign. Pneumothorax, positive. What do you think? Pneumothorax, yes or no? I'm going with yes. Sky, ocean, ocean, horizontal lines, no motion. So we have here sky, ocean, and then beach. Nice and grainy. Over here, here's the pleural line, A line, A line. You will see that those A lines repeat themselves, okay, in the setting of a pneumothorax because there is that repeating artifact. But on M mode, we see the barcode. So you could say barcode plus A lines equals pneumothorax, if you wanted to. So which one do you think is positive? Good, the one on the left. That's a recurring theme in my lectures. Somebody pointed out to me. I like to put pathology on the left side of the screen. So hopefully I won't. Hopefully that will continue for the test, right? So yeah, so you can see here sky, ocean, beach, sky, ocean, 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 ocean. When they're side by side, they're easy to pick out in M mode. What do you think now? Yep, didn't break my pattern yet, did I? Left side's got the pneumothorax on it. Right side, grainy, motion mode. Okay. Now there's something called lung point. Lung point is where you have it's the transition zone between where normal lung is sliding and where the pneumothorax isn't sliding. And we can see that here. So these are common tails over here that kind of slides back and forth, and then over here we see that there's no sliding once in a while as the patient breathes in and out. That's the transit. I'll try to freeze it here for you. That's the transition zone right there between pneumothorax and no pneumothorax. It is highly accurate. This is like pathognomonic when you see this. You can say, if you saw that pattern on the screen right there, you could say with very high confidence that this patient has a pneumothorax. Cool. Now, again, that lung point is the transition zone between where the lung is touching the chest wall and where there's air in the way, so it can't touch the chest wall. All the black stuff is air. This is a CT scan demonstrating that. Here's the transition zone on M mode. And we just had this the other day in the emergency department. This is from about a week ago. This is someone breathing over here with their lung normal, and then this is that same patient where on this side of this, so here's a rib shadow, here's a rib shadow. We see lung sliding here. We see the lack of lung sliding there. Burn that in your retinas right now because this is sometimes something that can confuse people. You want to make sure this thing slides all the way across. This transition zone or lung point can sometimes confuse people. Okay. Now, there's other conditions that can cause a pneumothorax to appear on ultrasound, even though there's not one there, right? So these are false positives. If you've got a lot of fluid around the lung, that can separate the lung from the chest wall, and you may not see sliding. If there's a big pneumonia, what we call consolidation, and maybe the patient's got a lot of chronic adhesions or adherent connective tissue between the lung and the chest wall, making it so the lung can't slide as well. Okay, so that fibrotic tissue over a chronic period of time can result in decreased ability for the lung to slide nicely against the chest wall. If there's a chest tube in place, and if the patient has advanced chronic obstructive pulmonary disease, particularly with lots of blebs, then you may not see sliding in there as well. So just keep these things in mind. In that young, healthy trauma patient, that's the ideal patient that doesn't have any past medical history, that this accuracy holds up very well in. Now, changing gears to pleural effusion. What does that mean? Fluid in the chest cavity surrounding the lung. The way you do that, it's a coronal view or it's a longitudinal view with the indicator pointed towards the patient's head from the side of the body. That's what coronal means. And what we're doing here is we're seeing the diaphragm with all this fluid around it. We can see it both with the sector and the linear transducer demonstrated here. Okay, and it's interesting because if you put that probe between the two ribs here, you can see that diaphragm right here. This is the liver, this is the lung, and what you can do is you can slide it right up into the axilla, and you will see the diaphragm right along here. Now, normally, you don't see the lung because there's no fluid up in the chest. What you see instead in the normal patient is this diaphragm and the mirror image of the liver up here in the chest. That's normal. That rules out fluid in the chest. But when you've got fluid, which is black on ultrasound, up here in the chest, in this coronal view in a supine patient. Well, now the sound can get past the diaphragm and into this fluid, and you'll actually see black stuff up there, and it looks like this. So it's the loss of the mirror image artifact that is the pleural effusion. Here's the diaphragm. Here's the kidney. Here's the liver. There's black stuff on the screen somewhere. Where is it? Is it between the kidney and the liver? Nope. It's over here above the diaphragm up in the chest. Now this, on the other hand, is what a mirror image artifact looks like. There's the diaphragm there. Here's the kidney. Here's the liver. Or that actually could be the spleen. They look very similar on ultrasound. Actually, I see a hepatic vein there, so this is likely the liver. But there's the diaphragm there, and you see the mirror image artifact across the diaphragm. That's somebody who has a dry chest. That's normal. So when you do the hands-on session, you should really see that. Which one's got the hemothorax? By the way, blood in the chest or pleural effusion, fluid in the chest, either one will look very similar. You'll just see black stuff up here. Acute hemothorax, before it congeals and becomes a clot, looks very jet black anechoic, much like pleural effusion would. Yeah, sort of gave it away. So this is, again, the left side of the screen where the pathology is. I gotta stop doing that. So how can you, you can differentiate some of these things sometimes between a transudate and an exudate and a hemothorax. Sometimes with the hemothorax you can see some debris in there, especially in dependent location. With a transudate, it's almost all jet black and very homogeneous, whereas with an exudate, sometimes you'll see loculations in there. There'll be some echoes floating around, things like that. What about the size of the effusion? Well, you could definitely pick up effusions less than 500 cc's, but it's really hard to quantify like how many cc's are in there. People are always asking me that. I have no idea. I just say, there's enough to tap. I can definitely make out a place for a needle to go to, and you can make a decision based on that. If I see a few centimeters of distance between the skin line and where the lung is, and then there's likely at least 500 cc's of fluid there. So, but if you've got somebody with an effusion large enough to actually cause hemodynamic collapse, you need to put a chest tube in that patient right away. Luckily, that's pretty rare. Some other things you might see in the chest, you might see structures here like these exudates here. You can see a consolidated, this is part of the lung that's all consolidated. Maybe this is some exudated material here. This could be an abscess. Hard to tell in a still image exactly what's going on. As you notice, I like to use a lot of video because I can make out a lot more about what's going on with these loculations, like flowing or not, or they have that rippling effect each time the heart beats. This is a hemothorax scene down here above this person's diaphragm. The probe looks backwards to me. This is a transudative debris seen here in this above this diaphragm here. If you want to do a thoracentesis or drain the fluid off the patient's chest or out from the chest cavity, you can localize that using ultrasound. The idea with ultrasound is to avoid doing biopsies here of these organs, unnecessary biopsies of the organs. You want to stay up here in the chest cavity to get into the fluid. And in fact, this is the lung scene down here, and this is the needle coming in here, and this over here is the lung, and all this black stuff here, that's all that pleural effusion. We're just advancing that catheter right underneath the transducer into that fluid space to try to retrieve the fluid out from this patient's chest. Many of these patients have cancer, and you'll get these ugly-looking fluid collections coming out of there.
You want to get the thing all the way past the fenestration. See the black line right there? You don't want to go in past that black line.
Which is all compressed here by the fluid to expand once you get the fluid off of there. Okay, now finally, what about pneumonia? This is the last topic we're going to go over here. Pneumonia, you can see it on a chest x-ray. There was a recent article that showed that ultrasound is actually more accurate than a chest x-ray is for pneumonia when compared to the gold standard CT scan. And so when you've got a consolidation is basically, the definition of it is loss of aeration of the lung. With ultrasound, the cool thing about it is that when you've got a consolidation there, ultrasound waves can now be actually transmitted through that consolidation deeper into the chest. And it looks basically like you're going to see here in a minute, it's sort of hypoechoic, wedge-shaped, poorly defined area. Sometimes you'll see air bronchograms. You'll see this within the consolidation. You'll see these bronchograms kind of hyperechoic and moving with respirations. The thing that the pathognomonic thing I like to think about is the hepatitization of the lung. And lots of things can cause loss of aeration. Certainly edema can cause that, pneumonia or can cause consolidations, a lung contusion, and atelectasis, or portions of the lungs that is not filling with air. And this is what consolidation looks like when it's due to pneumonia. You can visualize that on ultrasound the majority of the time, and it basically looks somewhat hypoechoic. And I really think this looks a lot like the liver. When I look at this, every time I see this, I'm thinking, is this the liver? And normally the lungs got these A-lines, right? And we talked about this quite extensively now. You see those rib shadow and then a pleural line, A-line, A-line. Whereas with pneumonia, we lose those A-lines and we have a consolidation sitting there. An air bronchogram can look like these hyperechoic, sometimes they're described as horizontal, though not always horizontal, hyperechoic lines with fluid in between the two of them, which is why we can see fluid always makes things more echogenic around it, which is why this is more hyperechoic and that's more hyperechoic, and the fluid is there in between the two. And if you use color flow, you can see some increased vascularity there in the chest, which normally you don't see because lung is filled with air, but when it's consolidated, well, now you can make out, especially if there's pneumonia there, you can make out hyperemia or increased vascularity in the lung. Very interesting to see that, where you don't normally see that. So this is, so which patient's got the pathology? Exactly, the one on the left. So this is what pneumonia looks like. We can see maybe the air bronchogram right here, where there's a little bit of air, hyperechoic kind of lines coming down, but there's fluid inside there, which is the anechoic stuff, surrounded by the hyperechoic walls of that bronchogram. And this is that hepatitization or that consolidation where it looks somewhat hypoechoic, but definitely visible, as opposed to over here where the patient's got A-lines. Another example here is interesting. This is all like weird consolidated lung, hard to see. Over here when you get next to it, so this is again that consolidation, and then they slide to the next rib level down. You'll see this rib's gonna bounce over here in a minute. We're gonna lose this consolidation, and then we get over here, right there. I'll stop it for a second. So this is the next rib level. So there's a rib level here. This is the next between these two ribs here. We can see A-line. We can see the pleural line, A-line, A-line. And then they're going to see that lung sliding back and forth. They're going to bounce up to that other rib level, which is where they see the consolidation. And so that's essentially how you would pick up a pneumonia. You'd be bouncing between the rib levels, looking around for something that looks poorly defined and hypoechoic, and maybe has some bronchograms and starts to appear to have hepatitization as opposed to having A-lines, which is what the normal part of the lung looks like. So when you guys scan this week while I'm in Australia, I want you to make sure you identify those A-lines with both transducers, the P21, your L38, and I want you to see lung sliding with both transducers and obtain also, not listed here, M-mode tracings on those lung slidings. I want you to look at all 8 quadrants of the chest, and then that usually goes pretty quick, and since you have a lot of time here this week, I want you to catch up and look at the gallbladder, kidneys, aorta, and if you have time after that, which you likely will, always helps to get that parasternal lung and that apical 4-chamber view of the heart as well. So I'd like to see all those things. My objectives will be posted up on Merlin, as well as the PDF of this lecture, because I know you like that too. Some people like that too. So anyways, thanks a lot, and thanks to my fellows and everybody else for holding down the fort while I'm down under.